Hi and welcome back to another video of Medic Notes. This video is on prostate cancer. Prostate cancer is the most common cancer in men in the UK, accounting for 26% of all male cancer diagnoses, and is estimated that 1 in 8 men will be diagnosed with prostate cancer in their lifetime. The majority of cases occur in older men, although 25% of cases occur in men younger than 65. Whilst the 10-year survival rate is over 80%, prostate cancer is the cause of death in over 10,000 men in the UK alone each year. Although the exact etiology of prostate cancer is the subject of ongoing research, it is widely agreed that the growth of prostate cancer is influenced by androgens such as testosterone and dihydrotestosterone. The majority of prostate cancers, more than 95%, are adenocarcinomas. Over 75% of prostate adenocarcinomas arise from the peripheral zone, with 20% in the transitional zone, and 5% in the central zone. And prostate cancers are often multifocal. There are two main types of prostate adenocarcinoma. Acinar adenocarcinoma originates in the glandular cells that line the prostate gland. This is the most common form of prostate cancer. And ductal adenocarcinoma originates in the cells that line the ducts of the prostate gland. This tends to grow and metastasize faster than acinar adenocarcinoma. Risk factors. Age. As the incidence of prostate cancer increases with age. Ethnicity. Men of Black African or Caribbean ethnicity are twice as likely to be diagnosed with prostate cancer in their lifetime when compared to Caucasian men. Family history is associated with increased risk of prostate cancer, however only 9% of prostate cancers are thought to be truly inherited. Genetic predisposition, although rare, also play a part, as men who possess the BRCA2 or BRCA1 gene are at greater risk. Other less significant modifiable risk factors include obesity, diabetes mellitus, smoking, and degree of exercise. For clinical features, patients can present with a wide variety of symptoms, dependent on stage of the disease. Localized disease can present with lower urinary tract symptoms, including weak urinary stream, increased urinary frequency, and urgency. More advanced localized disease may also cause hematuria, dysuria, incontinence, hematospermia, suprapubic pain, loin pain, and even rectal tenesmus. Any metastatic disease may cause bone pain, lethargy, anorexia, and unexplained weight loss. A digital rectal examination is essential if a diagnosis of prostate cancer is suspected, as most prostate adenocarcinomas arise from the posterior peripheral zone. The examination should be checking for evidence of asymmetry, nodularity, or a fixed irregular mass. The differential diagnosis of prostate cancer can be BPH, prostatitis, and other causes if there is hematuria, such as urinary stones, UTI, and pyelonephritis. For investigations, prostate-specific antigen, PSA, is a serum protein produced by both malignant and normal healthy cells in the prostate gland. PSA can be elevated secondary to prostate cancer. However, the PSA can become raised with several other conditions, including BPH, prostatitis, UTI, recent urological surgery, or urinary retention, reducing its specificity. This table shows the normal PSA level according to different age groups. Other investigations are MRI scan of prostate, biopsy of prostatic tissue, and CT TAP scan or PET scan for staging purpose. The Gleason grading system is a scoring system by which prostate cancers are graded, based upon their histological appearance. The sample of prostate tissue is assigned a score according to its differentiation. And the Gleason score is then calculated as the sum of the most common growth pattern, plus the second most common growth pattern seen. Higher Gleason scores are associated with a poorer prognosis. Gleason scores alone are not used to determine prognosis and recurrence risk, instead the score is used in conjunction with PSA levels and TNM staging. For management of localized cancer relates directly to risk stratification based on PSA levels, Gleason score, and T staging. For low-risk disease, most can be offered active surveillance, and radical treatments offered to those who show evidence of disease progression. Radical treatment options should be discussed with all men with intermediate-risk disease and high-risk disease with realistic disease control. Those with intermediate risk can also be offered active surveillance. Whereas for metastatic disease, chemotherapy agents and anti-hormonal agents can be used. In castrate-resistant disease, those who demonstrate evidence of hormone relapse disease can be considered for further chemotherapy agents, such as docetaxel. Corticosteroids can be offered as third-line hormonal therapy after androgen deprivation therapy and anti-androgen therapy to men with hormone relapsed prostate cancer. The mainstay surgical treatment for prostate cancer consists of a radical prostatectomy. This involves the removal of the prostate gland, resection of the seminal vesicles, along with the surrounding tissue, plus/minus dissection of the pelvic lymph nodes. This procedure can also be performed with an open approach, laparoscopically or robotically. External beam radiotherapy and brachytherapy are both commonly used alternatives as a form of curative intervention for localized prostate cancer. Androgen deprivation therapy is the mainstay of management of metastatic prostate cancer, and improves outcomes in patients undergoing radiotherapy, as prostate cancer cells undergo apoptosis when deprived of testosterone. Chemotherapy is usually only indicated in patients with metastatic prostate cancer. Some examples of chemotherapy drugs used include docetaxel or cabazitaxel. That's all for this video. Thank you.